This video is about endometriosis. My name is Kaur, a current fourth-year resident at George Washington University. Endometriosis affects 6 to 10% of women of reproductive age, 38% of infertile women, and 71 to 87% of women with chronic pelvic pain. Symptoms most commonly associated with endometriosis include dysmenorrhea, chronic pelvic pain, dyspareunia, and on physical exam, one often notes uterosacral ligament nodularity or the sensation of an adnexal mass. There are also many women who have no symptoms at all. Some more specific symptoms for endometriosis include deep dyspareunia, as well as a lower backache during menses. Endometriosis is also associated with urinary as well as bowel dysfunction, including perimenstrual straining, diarrhea, constipation, dysuria, and hematuria. Symptoms that are often associated with deep infiltrating endo include painful defecation and severe dyspareunia. The predominant thought process as to how endo came to be is through retrograde menstruation. However, the pathophysiology of endometriosis is not well understood. There is an understanding that endometriosis is causative of an inflammatory environment that may affect sperm function, thereby leading to DNA damage, as well as ovulatory dysfunction. And women with endometriosis are often found to have lower AMH levels. Endometriosis has a variety of visual appearances during laparoscopy that are demonstrated here. The more classical lesions are described as black or gunpowder lesions that are in the bottom left-hand corner of the slide. The less common presentations are often the red or clear lesions that appear vesicular in nature, or a peritoneal defect or a peritoneal window. Transvaginal ultrasound is the modality of choice when evaluating for endometriosis. MRI can also be helpful. However, initiating evaluation with the transvaginal ultrasound is recommended. A common finding at the time of evaluation with ultrasound is something called an endometrioma, which is depicted in the top left-hand corner of this screen. It's described in many questions as a cyst of low-level homogeneous internal echoes that appear as old blood. Further, MRI can help further characterize deep infiltrating endometriosis, which is shown via ultrasound in this slide as well. On the left of this slide, you can see a bladder nodule, which is then depicted visually in the cystoscopy view. On the right side, you can see deep infiltrating endometriosis of the bowel, and you can see the lesion via ultrasound on the bottom right hand of the slide, and then you can see it depicted visually here above that. Endometriosis is definitively diagnosed at the time of laparoscopy. However, empirical treatment is standard of care. It is important to emphasize with patients that endometriosis is a chronic condition that will require continuous lifelong treatment for many patients. The mainstay of initial treatment includes ibuprofen and some form of contraceptive. Most commonly, oral contraceptives are given in a continuous fashion, as it has been shown in studies when used continuously for 24 months to reduce pelvic pain and symptoms related to endometriosis. Many practitioners recommend starting at 20 milligrams of ethinyl estradiol and then subsequently changing that to a progesterone-only method if the patient is unable to tolerate the side effects of the combined oral contraceptive. Other options include a NuvaRing or a transdermal patch. However, the continuous birth control pills have been shown to be the most efficacious at decreasing symptoms. In those that desire immediate fertility with mild to moderate disease, surgical management has actually been shown to improve pregnancy rates and can be pursued in this patient population. There were no RCTs that looked at advanced disease and infertility and subsequent pregnancy outcomes. Further, in infertility patients, removal of any endometriomas can also improve pregnancy rates, and thus removal of any endometrioma in a patient that desires fertility and is undergoing an infertility evaluation is recommended. This slide demonstrates other treatments that can be used for endometriosis if patients are unable to tolerate progesterone-only pills or would prefer a method that wouldn't require them to take a pill every day. Depo-Provera is another option that could be offered to them. Another pill that can also be used in this patient population is Agestin, often used at 5 milligrams daily if 0.35 does not provide symptomatic relief. Typically, the way this works is they start off with NSAIDs and OCPs. They are reassessed in about 3 to 4 months, and if that doesn't work, then you can consider these second-line treatments. Another treatment is known as Orilissa or elagolix. It's a GnRH antagonist and has recently come on the market as something that works well for endometriosis and has been shown in multiple clinical trials to be efficacious. Another treatment in patients with severe symptoms is Lupron, or a GnRH agonist. Lupron requires add-back therapy if you are planning on using Lupron for longer than 3 months. However, it can be a really efficacious treatment in decreasing symptomatology for patients with severe endometriosis. It, however, is associated with mood changes in about 20% of the population. It also, by design, is associated with menopausal symptoms like hot flashes and night sweats, and thus patients need to be thoroughly counseled before initiating this form of treatment. Another form of treatment that has less evidence but is continuing to be used more readily are IUDs. There is consistent evidence that they have actually worked to decrease pain in very small studies with an N of about 40 to 50. However, a lot of providers have migrated to using IUDs after an excisional procedure to provide suppression, so that is another option for your patients. Laparoscopic excision of endometriosis should be considered in patients with severe symptomatology. There is some information that short-term improvement in pain and dysmenorrhea is associated with excision of endometriosis. However, we do not have a lot of long-term data yet to demonstrate improvements in pain long-term. And there are some studies that show that pain actually returns. Initially, there were a group of people that were doing presacral neurectomies for endometriosis patients. It was shown to have a very high risk given the location of the nerves that were resected, and low reward, meaning it did not show any difference or improvement in pain scores afterwards. The goal is to excise any endometriomas in a patient that's desiring fertility, and in those that are not desiring fertility, a TLH-BS with excision of endometriosis is what is recommended by most specialists with retention of the ovaries. There was a study that was done where they followed women for up to 11 years following that surgery, and most of them did not need a repeat operation. So we do believe that surgery works for these patients. About 15% of women will have recurrence of their symptoms, and the most common site of recurrence is the large and small bowel. We don't really understand if that recurrence is related to disease that was left behind because of its location to other important structures, or if it's actual recurrence of disease. And the biggest thing that patients have to understand is that this is continuous lifelong treatment, especially in the population that has severe endometriosis. Treatment of these women often requires a multidisciplinary team, and there are often many women that pursue other forms of treatment in concert with the allopathic treatments that we provide our patients. Some of those treatments, none of which have been proven to help, include acupuncture and dietary changes. Many women also often are undergoing concomitant pelvic floor physical therapy in order to help with their dyspareunia. This is the current staging system that exists for staging endometriosis. It was developed in 1985. As you can see, if you have complete cul-de-sac obliteration, you automatically receive 40 points, so you have stage 4 or severe endometriosis. I think when you're thinking about testing questions, looking at where the most high points are awarded is what's going to get you the most points on the test. If you have any places with dense adhesions, if you have more than 3 of them, you're automatically going to be stage 4 endometriosis. Or if you have deep infiltrations of endometriosis in the ovary, meaning like an endometrioma, you're going to have stage 4 endo. Because the staging system is thought to be very, very lopsided and doesn't really describe endometriosis as we currently understand it, given the field has grown so much, there is actually a new system of endometriosis staging that was just unveiled at AAGL this year, which I would encourage you guys to take a look at. I don't think it's something that you'll be tested on this year in CREOGs, but I think it's something that's important to know, and hopefully will be a way of us communicating endometriosis from provider to provider in the future.